I'm Kitty and Mary. I know all of you, which is really great. I'm really excited this is happening and that we can share our program with you guys, because you guys will probably be getting a lot of the field complaints about our program. And if you can know a little bit more about how we do what we do, you can either validate or invalidate those complaints. This is Ashley Taylor. She is one of our crisis intervention specialists. She's been doing CRT since before I was, but she works for emergency services at the CSB. She's also on mobile crisis, and then in what we call the big room, it's just the mobile crisis response center. Basically the ER of mental health. You thought you guys had a monopoly, turns out you don't. All right, so this is going to be where we started and where we're at right now. And okay, so Fairfax decided a community response team was necessary because we had 12 individuals who were making up a significant portion of our calls. Interestingly, we are still dealing with one of those individuals 6 or 7 years later. We made big strides for her. She's been a precedent setter, but it's it is an uphill battle no matter how you look at it. This started with diversion first. It's a county initiative to make sure that the right resources are going to the right people, that people aren't ending up in jail for things that are mental health related, and to really make sure that we're not just transporting the people to the hospital, letting them deal with it, and washing our hands of them. There's a demonstrated need. Mental health is a huge thing that we encounter in our field. Substance abuse is also very prevalent. A lot of our clients, and we'll get into this more, navigate their primary challenge pretty well for most of their lives. If they are an alcoholic, they can pretty much manage until they get dementia, or if they have a car accident and now they have 2 broken ankles and just all of their support systems are no longer adequate. So that's usually when we'll see somebody come on our radars, when there's been some significant life change or a disease progression that makes what they had been coping with now untenable. And excessive use of acute resources for primary care. We all know that we transport people to the hospital, and that is their primary care provider, and woefully insufficient. Lack of transportation. Medicaid has transportation to and from appointments. Medicare does not. That's a huge problem that we navigate. Social supports, people wanting to age in place, but their kids can't afford to live here. So the kids live in West Virginia or Tennessee, and they still live in Fairfax County, and they are without any of the newer generations helping them navigate their aging process. Home health aides for geriatric population. Again, Medicaid pays for this, Medicare does not. So it's 911 becomes the home health aid of choice. All right. So our superutilizer concerns. We've got a graph, primarily mental health. This can be anything from serious mental illness like schizophrenia to adjustment disorder, which is sort of a catch-all. But as you can see, these numbers add up to significantly more than 100 because most of our clients have more than one area of concern. Boop.
What's the jail diversion?
So jail diversion is people who've been on probation or put into a mental health docket so that they can get the mental health services rather than spending time in jail. We don't have a lot of people that's their primary thing. They typically will be with that mental health group. These are typically people who have a group home of some sort and some more supports, but they still call 911 excessively.
So the people who think that going to the hospital, they're not going to go to jail, right? Is that like a jail diversion?
No, unfortunately, not. No, but we all have those patients, right?
It's programmatic.
Yes, yes.
Episodical.
Yeah. All right, and So CRT 1.0, when Adam Williamson and I think Beth was also there, coordinated with our leadership, and they started the community response team. It was a 4-person team. There was a licensed clinical social worker or a licensed, there we go, that's why I brought Ashley, from the CSB, as well as a CIT trained paramedic, so that's crisis intervention training, a CIT peer support specialist, and a law enforcement officer from either the Sheriff's Office or Fairfax County Police Department. They would respond to referrals that they would gather from data or from phone calls and emails. And their tracking mechanism was primarily a spreadsheet. That went away with our app. We have a CRT app. Most of you have probably filled out a referral. Yes? I know Captain Torpy has. But we use our tracker primarily for our app for tracking these people. Unfortunately, it doesn't do all the things that an Excel spreadsheet can do. So now we have a hybrid system where we use our app and an Excel spreadsheet to really be as efficient as possible. So what's old is new again. So roadblocks. Some of our clients that we refer had active warrants. So you can imagine that would present a problem when you show it with a law enforcement officer. That door is not being opened. Or if it does, there's drugs on the coffee table. So the law enforcement officers know that there's some leeway of why am I here, what is the bigger goal here, but they can't ignore a lot of that stuff. So right now we go out with a team of 2, myself and a clinician, or I'm at Harris and a clinician, and we can get PD as backup. So for our particularly volatile clients or people who've had some intense encounters with the police department, we'll get PD for backup as needed. PD also created a co-responder team of their own, and we'll talk about that more later. There are 4 teams in the county now. Generally, hours are 10 to midnight. COVID pandemic affected our peers. Our peers are not medical people, so while we were used to responding to COVID patients, they were not. This led to some pushback, and they elected to be taken off of the team as a regular basis, and now they are added on specifically for people who would benefit directly from encountering a peer support specialist. The CSB also developed what they're calling a post-response team, where it is a peer support specialist and a clinician, usually a behavioral health specialist, so Ashley will tell you more about what the levels actually mean. But one of our clinicians pairs up with a peer support specialist, and they work with individuals who get referred from our team as well as from emergency services at the CSB. That's the 2 primary sources of referrals. Sometimes it comes from like Board of Supervisors or things like that. And then our referral app, when we did launch that, are you waving me down for time? Okay, good, sorry, I just saw movement from back there. A little scroll. Okay, with our referral app, we ended up with more people than we could adequately help. So there was a second team added, and after that was established, I came on because it seemed safer. We do have plans to flesh out our backup CRT firefighter program. It hasn't really happened yet because of budgetary constraints and training process constraints, but it is absolutely something that is in our minds, because right now if Ahmed and I take off, then there's not a firefighter to backfill us. Questions so far? You guys are awesome. All right, how it works now. Our primary referral source is the fire department. That's that big, more than almost two-thirds black wedge there. The CSB accounts for 9%. Sheriff's Office is 1%. That's usually our evictions come from our Sheriff's Office. Somebody getting evicted, naturally a mental health concern there. DPSC, dispatch, gives us 10%. That can be anything from Board of Supervisors offices to, I think we've had APS referrals, and INOVA give us referrals, and then 11% from PD. We do plan to attend roll calls for the police officers so that they can find out more about our program, because our plan is not for us to be a disparately firefighter aimed team, but just because our app is within the fire department, I think there's a natural tendency there. So we process the referrals. Our clinicians are typically our referral processors because they have more access to the electronic health records than we do. If you guys thought HIPAA was fun, there's a whole bigger world of patient privacy that involves mental health that we are not really full participants in. So we enroll individuals with 6 encounters in 60 days. That is our magic number, 6 and 60. We made it firefighter friendly because it's a multiple of 10. And it's not a hard and fast rule. If you have somebody with 5 encounters in 30 days, we can extrapolate and imagine what it's gonna be in 60. So please refer those people and we will evaluate them for sure. A lot of times, even like 3 and 2 weeks, we want to nip that behavior in the bud before it becomes their habit. So it's not a hard and fast rule, but please try to sell it in the description part of your narrative in the app, because you know the clinicians are human. They see 3 calls in 2 weeks, they're gonna be like, nope. But we want to be able to capture these people. So once we have this patient client enrolled, I use the terms interchangeably, but CSB specifically calls them clients or consumers. Then we research their needs. We can look in a program called Point-Click Care, where we can see everybody who doesn't opt out, hospitalization records. It's not Epic. Epic is a challenge to maintain access to Epic, but it gives us a really good overview. We can see if somebody goes to a hospital in Silver Spring. We can see if they go to Inova Loudoun, Reston, and that helps because while we have really good relationships with the Inova social workers, we don't have those relationships with Loudoun and particularly Reston, or out of state. So that helps us track our patients and see where they are in the hospital world, which makes us more efficient. There's no point in us going to do an outreach visit if somebody's in Silver Spring. We also will coordinate with APS to see if they already have an APS worker assigned. A lot of times if you put in a referral, we'll say, have you also put in an APS referral? This is because APS values first-person information, and if we just tell them, hey, look, this sounds totally credible, it really needs to be investigated, that's not sufficient for them. They need it to be the first-hand people, and you guys in your new roles would be very good advocates for people putting in APS referrals. Then we do an outreach visit, so we'll go knock on the door. We typically don't call first, because if we call and they say, no, don't come, then we're stuck. But if we just show up and knock, half the time at least they answer. So that's a pretty good rate. Then after that, it's coordination. So we can refer to a couple different programs. We can refer back to APS. We can refer to adult services. Some of you have probably gotten emails from us saying this meets criteria for adult services, but not APS. And that will help them get some in-home care, either on a free or a sliding scale basis. We also can refer to code compliance. That's been somebody that we've used as well. And then there's probably one of our favorite partners is RAFT. It's an organization in the Northern Virginia area that does outreach for people with dementia, and they can even work with individuals without a diagnosis for 60 days and help them get that diagnosis, which unlocks a lot of doors for resources that they need. And after that, the clinicians love this part. They come back and they do about 3 hours of paperwork. It's intense. The documentation involved on this it makes our EPCRs so much better. But yeah, usually they have to do an emergency eval, which takes about an hour. Sometimes people are really good and quick at it, and it's a short visit, so there's not a lot to document, but it's extensive documentation, which does limit our outreach visits, because I can't just say, okay, we've got all day, let's go see 6 clients, and then they'd have 6 hours of paperwork on the back end, which would be, they wouldn't be friends with me anymore.
I think something else that's helpful in with client history when you guys are doing referrals, if there's other people in the home, collateral's really good. sometimes the folks that we're engaging with don't want to engage with us, but there's other people around that can help us get connected to them.
That's a really great point. If
Yeah,
there's,
I did one with a neighbor once.
yep, neighbors are good,
Like, paid
children are
bills
great.
And did all this stuff, so I asked
The
them.
one with the leg,
What's that?
was that the leg one?
No, she was in, I was working overtime, she was in Burke.
Oh.
But the neighbor came to the call and said, she wouldn't have power if I didn't pay her electric bill. Like, those, and I said, can I put your name down? I'm gonna put a report in the CFPD.
Yeah.
Because she was a frequent user.
Those are really helpful. And when we get there, then we can fill out a release of information so that we can still contact that neighbor. We're allowed to get information from anybody, but we can't give it out to anybody. So if we get those releases, then that really helps develop those relationships that can get somebody to the definitive care they need. All right. So really what CRT does is we want the appropriate services going to the right people to reduce their dependence on 911, right? That's our mission, is to get people to have something besides the fire department. We've all run the call of the little old lady who calls at 3 in the morning, and the best solution for me is to take her to the hospital because then I get to go back to bed. But that's not the best solution for her, and that's why our team really exists. A lot of our clients, we solve problems for people who can't. So a lot of times it's people who won't, right? That's where the mental health component comes in, and we work with our clinicians to be like, oh, they have borderline personality disorder, and so we're going to try it this way. Instead of just presenting cases logically, logic doesn't always work.
I think also, like, historically, specifically in the mental health population, individuals have been taught to rely on the system, and now there's been more of a shift for them to be independent, but especially like older adults, all they know is to rely on the system, and so it's hard for them to think outside the box and do other things.
Yep.
How does your homeless population?
That's one of our biggest challenges, homeless people, because we can't find them. We had a referral from Centerville. Very respected people referred this lady, and it sounded like she could absolutely use our services. And when we asked for a description, they said it's a 23-year-old African-American lady. And so we can't just go shout this girl's name at everybody who fits that description. So if you are going to refer homeless people, specific place where you always see them, or incredibly unique identifying characteristics.
How's your approach though? I mean, that's got to be awkward.
So we usually lean on our partners in the CSB called PATH. Their specialty is, to put it in firefighter terms, they basically sneak up on homeless people and get them services. They are very good at being convincing where we are not. So, and Ashley can use a lot nicer language to describe all of that. But they specialize in our homeless population, and they're also an outreach team. So our job is usually to connect them to this person and then back away and let them do their thing.
They also tend to have habits. So like time of day, if you can say they're generally in this spot around this time of day, then we can focus on going at that time. So like you see them out on the street panhandling, they usually do it at certain times of the day.
Gotcha.
Yep. Yep.
So in the instance where you guys can't contact the homeless, can we give them some way to contact you?
Yes. In theory, make sure you put in a referral for them first so that they're actually a client, and then we will typically reach out to you to get you information, because if we just have some homeless person calling our program phone, that will be confusing at a minimum.
To those that emergency services is always available, so you can always give them the regular office number, and then we can support them with getting connected to wherever they need to get connected.
And that'll be highlighted at the end, that number, so you guys can all put it in your cell phones. Questions? Awesome. All right. I know I broke all the rules of Instructor 1 with this slide, but it's more to show you that there's a lot of resources, so it's text acting as a graphic. Our internal and external partners. Emergency services, that's the umbrella in the CSB that we fall under. Social workers at the hospital, hugely important, because specifically to our homeless population, they go to the hospital and the hospital will often provide them with our contact information or call us when they're in the ER, and we can divert from our previously laid plans to going to see whoever's in the ER right now. Adult Protective Services, we have a great relationship with Adult Protective Services. We have bi-weekly meetings with them just to discuss our cases in common, and that's one of our most long-standing relationships outside of the CSB, and we value it a lot. They do joint visits with us. If we can't get in the door and they can, we'll go with them, and vice versa. And then a lot of care coordination. Code compliance is a different animal, right? We want to make sure that, particularly in our hoarding cases, that we're on the same page with these programs, but they're not HIPAA people. They're not always invested in the patient's mental health. They have a different mission, right? So we want to make sure that we use that cautiously. Detox, we work very closely with Detox. Chantilly Detox is part of the CSB. So what's really great is in our electronic health record, their notes are right there with our notes. Unfortunately, due to some of the regulations, firefighters are not allowed to access those charts, but we get our clinician friends to do that for us. And then on here, everything, I did add at the end, our EMS supervisors and specialists. Chris Seaman was instrumental in getting one of our clients in Tyson's to really participate with us. I know that Easton Peterson over in West Springfield has really helped us get in the door with a client, and now she's in definitive care. And then our fire station leadership team. Sometimes our clients duck us, right? Like, this is a friendly face in a friendly uniform, but when I show up and they know that they've been yelled at by B shift, and I come looking like them, that door doesn't always get opened. So we will sometimes provide the information that we want to the fire station leadership team, saying, hey, they're ducking us, but they still call you. Give them this when you see them again, and call us. And that's been very helpful. Anything on here that you wanted to specifically speak to? No. Okay. Yeah, lots of resources, and none of the consumers know about these, right? They don't know how to access Meals on Wheels. They know, everybody's heard of it, but they even changed the name of the program to Home Delivered Meals, so now they can't even look it up. So our ongoing challenges, 42 CFR Part 2 is our biggest challenge, in my opinion. It's a federal regulation that basically says unless somebody is actively dying from their drug or alcohol use, somebody who's in a 42 CFR compliant organization cannot tell us about that, and that we can't access information related to substance use. It hinders our paperwork, but when we are out and about in the field and taking care of these people and talking to them, they can tell us anything they want to. It's just other agencies can't tell us. Data capture. So we have Power BI, and we've got 2 versions of Power BI, which is pretty great. We have a CSB side and a fire department side. They help us look up police calls, because while I can access image trend, and I've got all the EMS captain rights on that, which is really fun when you work overtime, then I can't see what the police calls are looking like. So if somebody is abusing the police version of 911, but has no fire department calls, we still have to work with them and try to figure out a solution there. And that's what our CSB Power BI does. Reportable measures of success. How do we define how successful we are? How can you prove a negative, right? Our data shows that on average, once we get involved with a client, the 60 days prior to that and the 60 days after that show on average a 50% reduction in calls. That's not 0, right? Everybody would wish it was 0, but if you're getting up every night, now you're getting up one night a tour, that's huge. And then our care coordination, interagency relationships. APS has great boundaries. And while we can hear from our firefighters that this needs to be APS, their criteria is different than we all perceive it to be. And if somebody is willing to get help, then APS will not open an investigation in most cases. So
You get involved with CPS, Child Protective Services at all?
we get very few child referrals. Like, I've had 3 in a year and a half. But 2 of them have had CPS involved. One of our clinicians actually left CSB to go work with them, and I was like, well, I'm just gonna make sure I keep your phone number in case I need it. But we get so few that we don't really have a direct relationship with them right now.
And you guys can make online referrals for both CPS and APS now.
But with APS though, they have to want your services, correct?
APS is voluntary, yes. They can decline APS, and we just keep knocking on those doors.
But the client's ability to decline those services doesn't abrogate our responsibility as mandated reporters.
Oh, no, I get that, but like when I was the shift leader at 5, we had an individual we ran all the time, and we referred to APS, we're like, well, there's nothing we can do. We've had several complaints.
But there are some people that think that one fixes the other, it doesn't.
Right.
With APS, I will say one of the places that their boundaries and willingness to participate it's less of an obstacle when there's issues of capacity. APS does capacity evaluations as to whether somebody can really care for themselves, essentially. And that is, if you think it's a capacity issue and it's already been an APS case and they turned it down, highlight again that it's a capacity issue, and we'll try to really make them take the case if we can.
There's some like key things there that I like whenever I'm looking to refer somebody to APS. It's like I'm looking in their kitchen, I'm looking in their fridge, I'm looking to see in their bathroom if they're able to, and like highlighting things where I'm like, hey, here's some reasons why they're unable to care for themselves, and that's usually
Right.
a way to make sure that APS is more likely to be able to intervene.
Mm-hmm.
Like the ACE form, you're filling in your observations. I draw this conclusion because of these observations.
Right.
It can be helpful.
Yep. And while the form for filling out APS referrals is great, if you want to talk to a human, I highly recommend doing that. We can definitely get you their phone number, but their best hours are during the week, 8 to 4, and you can talk to somebody just letting them know that you want to see if this is a case or what further information they might need to take the case, particularly in ones that have been turned down.
Hey, Katie,
Yeah.
I don't know if you're familiar with the Holliston case, but with that situation, we got called a lot, like 2-3 times a day. Is that something we need to refer to CRT? I know it's been going on for more than 2 years.
We already have a referral.
And it's funny because I did mention that their capacity evaluation needed APS.
Yes.
Holly.
Oh, Holly Hill?
We actually went there yesterday,
Oh,
just to update you guys. Yeah, I was very proud of myself.
I've been there 6 times in one day.
Our unhoused client engagement, again, homeless people are tricky for us because of finding them and then the many reasons why they might be homeless. They're not always the most embracing of help. And without solving their housing crisis, a lot of times they don't want to interact with us. But that is why we refer it to our special teams. And then re-referrals, CRT rekindles. We ended up with almost 100 active cases at one point because there was a lack of clarity on what it meant to close a case. So right now, CRT is operating with the understanding that if somebody gets re-referred after they've been closed, that is not a necessarily bad thing because it gives us an opportunity to re-engage. If we keep knocking on the door and they keep not answering, we're not going to keep going out. We're going to wait until there's a new referral, and we're going to wait until we have more information or a new mandate. If we can go back out and talk and say, hey, look, you've called 911 30 times in the last month. I know you didn't want to talk to us before, but like this looks like it's worse, right? It gives us different angles to approach the problem from. So please, if something seems like it's been closed, reach out to me or Ahmed and see if you want to see why and if a re-referral would be helpful. You raised your hand.
What is the timeline, what the expectation on average between putting in the CRT and a patient home visit or finding them somewhere?
It varies, so that's not a great answer. But generally, we try for 2 weeks. We had a big influx of our dispatch center giving us referrals. So we had 20 referrals in one day. And that was really difficult to sort through. What's a good referral? What's not a good referral? How are we going out and addressing these? And they were extra tricky because they were not necessarily response generating 911 calls. So it's when someone calls 911 and doesn't get a police officer or fire truck, but still has abused the 911 system, which is an area that we're figuring out what our metrics really are on that. So that led to a backlog where we had been at a 1 week response average, and then it was 2 weeks. If it doesn't look like something has happened, there's typically a reason, either a mismatch in the data, and we can't figure out who this person actually is or where they are. So if you see any kind of lag, please do reach out to us on that. And you process more referrals than I do, so if there's anything you wanted to add on that. Okay. All right, this part's more Ashley. So there are 3 teams now. Well, really 4 if you count post-response, but we're not gonna count them right now. So there's CRT, it's 2 teams, Monday through Friday, 8 to 4. There's only 1 team on Mondays and Fridays because we have a flip-flop schedule, but 2 teams the other 3 days. And we just gone over all these things, but we are not emergent response. So I have added on to calls on particularly well-known clients, but it is not the norm. My clinicians get scared when I drive like that. But our goal and really mission is the overuse of 911. So if somebody fits that description, we are likely gonna be involved. I'm gonna let Ashley talk about the different levels of mental health provider, and then we'll go from there. So this is Ashley's turn.
So for the clinician part, primarily our BHS2s, which is a behavioral health specialist, work with CRT, and then sometimes the crisis intervention specialists work with CRT. And the main difference is that CISs are licensed, and then the BHS2s are working on their license. So they're newer to the field, but they still have us as backup. I think for the calls, I have seen like some referrals, I don't know from you all specifically, but it doesn't meet the CRT criteria, but they still, like, there's concern and you guys want some engagement. I think that mobile crisis would be a good option for that. And you can just call our main line and say that you want to put in a mobile crisis referral and say what's going on. So like you went out on a call and this person was engaged in some sort of risky behavior, you thought that they were unable to care for themselves, and then our mobile crisis unit can go out and respond to that. Because they're doing like urgent calls, but also outreach, since we now have our co-responder units, which are 7 days a week now. There's 4 teams throughout the county, and they can do those immediate 911 calls. For co-responder and mobile crisis, it's all CISs for that. So those are the licensed individuals. That's like your talk therapist that you would go see. We just happen to be doing it in a different role.
What would be like a line between like emergent, where I would see somebody, okay, this is an emergent response, I'm a co-responder, versus somebody who you think, okay, mobile crisis would be more appropriate?
Co-responder, like when family members call and they're screaming and crying, you should call 911. But when they're calling and they're saying, I have concerns, like my loved one hasn't been eating for a few days, they haven't been sleeping, that could be more of a mobile's call. For an individual that has like been out all night, they have some sort of like serious mental illness, maybe they're like wreaking havoc in the neighborhood, that might be a 911 call. They need more of an immediate response. Another mobile's call, I think we get a lot of referrals to like the homeless shelters as well, or schools, stuff like that, where they like want some sort of intervention, but they want a softer approach. In theory, mobiles can go out without a police officer and people like that as well, but it really depends on like the level of risk on whether we are or aren't going to go out without a police officer.
Were you asking in your context, wherein you may be calling and you're trying to make an informed choice about which resource you're asking for?
Yeah, also, I don't think that
Okay,
was.
so we are 911, so if 911 happened to be on the scene and you're deciding between the two options, just to frame the context of your question.
Right, yeah, that's also a more direct way, yeah. So if we're called to the scene and we are engaging with somebody, co-responder is, okay, we're thinking immediate risk.
Yeah, I've
Their life and
seen
health, yeah.
at dispatch where like maybe patrol is already at a call and they're like, is there a co-responder available? Because they're not sure. I imagine that you guys have that option to do that.
Yes, we do.
We can do that
So
too.
then you can do that, and then let's say like co-responder isn't available or the situation has been resolved, then you can call our office and put in a referral from mobile crisis to follow up. Sometimes patrol will do that too. Maybe it wasn't like super alarming, they didn't need to put them under an ECO, but they're still concerned about their overall presentation.
Okay. I think that like, and this is, I think I dealt with this with Dr. Dan maybe more than you, a gentleman who wouldn't take his meds and his parents were concerned. He wasn't in immediate danger of life and health, but like you could tell that he was definitely struggling. And so I think of that as more of maybe a mobile crisis.
Yes.
That definitely sounds like it.
The ability that if you needed to leave, now it's awesome when mobile crisis, you can do a direct, high handoff, but that's not always an option. Ultimately, in order to be a mobile crisis case, this would be something that I could leave and live with myself in terms of doing right by the patient if this was a gap between providers being there, is the way I organize it.
So if you're not doing that, you're left between the paperless ECO.
Yeah.
And if it's a mental health condition or a psychiatric illness, you need somebody who has the authority to pursue a psychiatric ECO. That is mobile crisis.
Yeah, that would be any clinician.
So that is either we call mobile crisis and we stay and maintain possession until they come. There are times that you make a calculated decision about the imminence.
Yeah.
And that's a question that I just wrote to ask at some point. So what is a reasonable minimum response time expectation or goal for mobile crisis being called to the scene?
That's a good question.
Or a range?
Yeah.
Somewhere between X and Y?
Theoretically, between like 24 and 48 hours. Yeah, that's best case.
But we can transport the patients, if they'll be transported, we can transport them to Merrifield as well.
Yeah. Yeah, so I'm just thinking about the patient who
Who won't?
won't go, right?
Right.
And they need to take, meds, but I'm not worried that they're going to die from their illness, their mental health crisis within the next 48 hours.
Right.
But long term, I'm concerned about that.
Yep.
Yeah, I think that's a good mobile crisis referral. But the other option is we do have the ability to call the magistrate and request a paper ECO. And then if we got credible.
As the pattern I was trying to create, I didn't want to put you on the spot. There are times that they don't meet criteria for paperless ECO, but they are a danger to themselves. We lack the authority to take them against their will, and the only pathway to gain the authority ingredient is through a mobile crisis as a petition to a magistrate.
Yeah, but any of our clinicians could do that. So if you just call the office, any clinician could support you with that or supervise.
So you should have to paint that picture of what exactly situation you find yourself in. God, what's the name of the guy that it was all based on? I'll share it, it's on my hard drive. Marcus,
yeah.
criteria.
Correct.
Have a good categorization that helps guide me every time I forget what's the thresholds. So I'll make that available on the
We have a little
classroom.
cheat sheet, I remember.
Yeah.
That's gonna be the next slide.
I
assume from Merrifield,
Yes.
even in evening hours, that's the location for coming?
Yes, we're all right there together. Most of us do all of the programs. There's a few of us that only do like one or two. And mobile crisis is 24 hours.
Yep.
Oh, it says that.
But it says it in yellow, so it's good to say it out loud. All right. Next slide. This is too small to see from the back, but I emailed it to John Winstead, who will get it to all of you because the printer here does not love me. Okay, good. So it's not just me. That's validating. They teach me all these fun words. So on here, just for those in the back who can't see this far, emergency is at the top. This is definitely our co-responders, but also can be mobile crisis. Mobile crisis does go to barricades. So that's an instance that you'll see them there emergently. Urgent is going to be sometimes co-responders, sometimes mobile crisis again, if they seem safe-ish. That's probably where that would fall. Low level, there's an additional tool that you guys have probably all heard of is 988. Every client that we get pretty much gets a 988 card. 988 also has a first responders line. I'm going to read it out to you since it's illegible. It's 703-516-6776. This is for you to call while you're on scene with somebody, and also you can leave it with them to call after you leave if they don't want to go.
But not that line. The next one.
No, that one. I checked.
Oh.
Yeah. So that indicates to 988 that they've interacted with the firefighter.
Okay.
988 is, there's a special term like geolocated or something like that, where if you have a Texas cell phone and you call from Fairfax County, you still get Texas 988. Yeah. So calling the direct numbers gets you a little bit more. 988 also has a response team that can come out and talk to you. One of our clients actually got re-referred to us because he abused 988. But typically that's not the norm. The 988 goes out and they are just the right level of interaction. Questions about that? Awesome. This will be distributed to you guys electronically. Where do we see this? Sorry.
Oh, because it used to be, but now it's 24. Gotcha. Mm-hmm.
There you go.
You emailed that to Winstead, you said?
What's that?
You emailed that to Winstead?
Yes, but I emailed it today, so he hasn't sent it
I
yet.
put it on the Google Classroom on what I posted yesterday for the ECO alternate pathways. And I sent an invite to the fly card lieutenants. As soon as I get the roster of everybody's names for the captains, I'll make sure you have an invite for the Google Classroom where I can share stuff.
For detox down at the bottom, they want to speak to the client, so like you can call right there in the moment and then put the client on the phone. They can't be having any like suicidal thoughts. It's just if they wanted to detox from some sort of substance.
And their BAC needs to be below 0.4, which sounds horribly high, but above 0.4, hospital.
Oh, yeah.
It is also part of detox diversion when if the van comes out to get them, the patient getting into the van under their own power is part of the test. So do not help them. Been yelled at before. All right, last one. Contact. So I put Ashley's email up there. Ashley is part-time on our team, so please don't bombard her with questions. Instead, bombard our boss, Nick Thomas, or myself or Ahmed. We're all on there. We all got lucky and don't have any numbers in our emails. Then there's also the CRT phone numbers. If you, for some reason, have an affinity towards one of the firefighters, Ahmed carries the 703 one and I carry the 571 number, typically.
The emergency service number is the one that's answered by clinicians all the time, 24/7.
Yep. Questions?